Good afternoon, everybody. A warm welcome to this Advanced Knee Symposium being organized by Biotek. It's our pleasure to have with us a group of eminent faculties to discuss the not very commonly discussed part of the knee. So we're going to focus on the posterior and medial aspects of the knee. And we've got a stellar group of faculty to interact with us. I'll start by welcoming Dr. Deepak Joshi, who's a professor at the Sports Injury Center in New Delhi. Welcome, Dr. Deepak. Next, we have Dr. Amit Joshi, sir. He's an eminent arthroscopy and orthopedic surgeon from Nepal. Thirdly, we have Dr. Rajiv Gupta, another well-established orthopedic surgeon from Jaipur. I would like to extend a very warm welcome to all our eminent faculty, and myself, I'll be Dr. Sumit Banerjee, additional professor of orthopedics at AIIMS Jodhpur, will be joining them. We will be going through a couple of lectures and talks on the PCL and MCL, and then at the end of it, we will have a lively case discussion on how to manage and some tips and tricks, hopefully from the esteemed faculty. So to set the ball rolling, I would like to invite our first speaker, Dr. Deepak, sir, to talk about PCL reconstruction. Over to you, Dr. Deepak.
Thank you so much for the kind invitation and nice words. So I will be talking on PCL reconstruction. So is my slides visible?
Yeah, we're good, Dr. Deepak.
Yeah, so I'll be talking starting from the basics. Then I'll be covering the surgical part of the PCL injury and the PCL reconstruction. So the talk is aimed for the beginners and also for the people who are interested in doing this part of the knee joint, which is, I think, has evolved and it has become very important. So when we started doing our arthroscopy way back in 1998, at that time in the conferences and the webinar and the seminars, so we used to be taught that PCL need not be reconstructed. It heals by elongation. It heals itself. So now over the year, I think last decade or so, the PCL is a very, very important ligament of the knee joint. It is the central ligament of the knee joint, and it is very, very important when we treat knee as a whole. So what are we talking about? We are talking about the ligament, which is very, very big. It starts from the medial femoral condyle, as you can see in this picture, very, very broad, big insertion onto the medial femoral condyle, consisting of two distinct bundles, as is seen in ACL, the posteromedial and the anterolateral bundle. The anterolateral bundle is a thicker and the interior bundle, and the posteromedial bundle is the posterior bundle. So, same as with ACL, the functions are twofold. It's a primary restraint to the posterior tibial translation and the secondary restraint to the external rotation. And whenever there is a tear, the joint sags, there is always a increased pressure onto the medial side as well as the patellofemoral side of the knee joint, leading to the early arthritis. It's a stronger cousin to the ACL, sometimes missed on examination. So the player is playing on field, he gets an PCL, maybe grade 1 injured, because there is no swelling and no pain associated. He gets up and he starts playing as compared to the ACL where it is diagnosed on field. MRI, if done initially, they may report normal, and mostly in our setup, the patient always comes late when there is a sag and the patient is either the patient comes with an MRI with an PCL injury or a avulsion, or generally the patient presents to us late in our center when it's an isolated sort of injury. Common mechanism of injuries are the dashboard injury, the road traffic accident with the bike injuries are very, very common. And the mechanism, sometimes the patient's unable to elicit the mechanism, which by how he falls. But most of the time, it's an hyperflexion injury, falls on a flex knee, or sometimes in a hyperextension. The people who comes to us are wrestler, wushu, and other martial arts player. So in those, the injury is always complex. They are unable to explain how they got injured somehow, but somehow they get their PCL injured. So in such cases, one should always do a very detailed examination. Symptoms, it's not classical in very low grade 1 tear, when it is a 0 to 5 millimeter sag and the sag is not there that much. Swelling is not there much. Often the player keeps playing after the injury. It is missed as a minor sprain by the players. And so often, why it happens, whenever there is injury to the PCL, there is a localized hematoma which acts as a splint, which prevents the tibia move backwards for the first few months, and it may be missed on the examination then. So always, whenever you start examining the knee joint, always look for the telltale sign, which is a abrasion or a contusion on the front of the knee joint. Always one should be, air should be up, and for the residents, this is that the newer fellows, that one should always look for the PCL, and it's a clinical diagnosis that is more important. So as you can see, this postgraduate is looking at the first, this is how I teach, and the moment you start examination, always start with a sag. Look for whether there is a tibia is in front or post behind as compared to the normal knee. So before you start for examining, looking for the ACL, one should rule out the PCL. The sag sign on hanging, the posterior drawer, as you can see, is again one of my fellow is doing. So sitting on the knee 90-degree, relax, look for the step and apply a posterior force, directed force, and look for whether there is any end point or not. So always look for the sag. So this is a grade 3, very older presentation of Dr. Chaudhary. So you can see there is a loss of sag. When there is a loss of step and there is a sag, then it is probably grade 2, and if it is going further beyond, it's a grade 3 injury. So sometimes when the patient is very conscious and he's not allowing you to do a draw test or a Lashman, reverse Lashman test, and it's painful, then you can do a quadriceps test. So the basis of this test is that you can see this is my contracting the quadriceps. In this, the tibia goes front. So it is basically pull of the ligamentum patellae, which pulls the sublux tibia anteriorly and is able to shift the tibia onto the in front of the femur. So the other thing, if whenever you are in doubt, stress X-ray is a very cost-effective and reliable method. You can do a stress X-ray bilateral lateral view. The posterior directed force is applied on the plate, and the posterior tibial translation is compared on the both sides. So it's a cost-effective and reproducible method. And when you see on an X-ray, this is how the lines are extrapolated from the posterior border of the shaft of the tibia towards the Blumstedt line. And when measure the perpendicular distance where the Blumstedt line ends and the this perpendicular line, if the difference is 4 millimeter, up to 4 millimeter is considered normal. If it is 5 to 12 millimeter, it's an indicator of isolated tear, PCL. If it is 12 millimeter or more, probably some PLC is there. And this MRI, often it looks normal. It's a normal MRI on the first, or sometimes you can actually see the ACL is not that looks like normal. It is actually PCL tear where there is this tibia is subluxed onto the posteriorly. Arthroscopically, it's only very rarely I have seen that the PCL is absent. Most of the time the PCL is there unless until there is an avulsion. Complete absence is rare. So indirect signs are ACL laxity, cartilage lesions on the medial or the patellofemoral area, and you can often see an intact PCL. So that's a sloppy ACL sign. So that's a small video, very old video of ours where we did a double bundle in this patient. So you can see that's the ACL looks, PCL looks okay on the medial side, but it actually the ACL, which is floppy, and when we do an anterior drawer is given, then the ACL becomes taut. So it looks like as if it is an ACL injury. So the beginners have to be very, very careful. So here the double bundle has been done, and you can see the sloppy ACL has been become taut. So when we have diagnosed it, how do we manage these cases? So if the displacement is less than 10 millimeter on stress X-rays, if the patient's symptoms are not disabling, means that if the tear is grade 1 or grade 2, we can always do a conservative treatment in such cases. and no clinical instability. If the patient complains of clinical instability after a good rehab, I think we can go for the reconstruction. So surgery again, more than grade 3 or more, or even in a lower grade with a disabling symptom, not patients not happy after good rehab. Patients who are young, active, and they have an interest in sports within heavy duty activities and a multiple ligament injuries. How do we do this? Grafts available with us are autologous. In our part of world, autologous is the most important graft with us. So we have quadriceps hamstrings and patellar hamstrings that we take more often at our center. And now we are taking more and more peroneus longus also when we are doing a multiple ligament injuries. So allograft not available with us. Achilles tendon is very good when the PCL reconstruction has to be done. I have seen many people abroad in the West, they are doing allograft of Achilles. And again, we can do a tibialis anterior or the posterior tibial tendon. So we have lots of allografts available, but not in our parts of our fixation methods. We can do a bias screw. We can put button on both the sides. We have good lots of. When we started PCL way back in 90, I think 8, we had only metal screws with us, and now we have lots of fixation devices available. So not that a big deal as far as the implants are concerned. We can have loops, we can have variable loops, we can have fixed loops, buttons, and bias screws. So fixation part is now taken very good care with the industry coming up with a very good and stable sort of implants. So this is how we start the one of the video of a single bundle ACL here, PCL here, sorry. Just a minute. So the first step is making a posteromedial portal. So we place the scope in the posteromedial space of the knee joint, and we pass a needle between the condyle and we should not penetrate the vein. Always look at the vein, should not injure the vein, because a nerve is along with the vein, then we have a good amount of paresthesia. So we make a posteromedial portal. It should be good enough. So this is probably the most important. The needle should come at an angle where it reaches the posterior horn of the meniscus, and then we debride the septa. The knee is kept in full flexion, because in flexion the vessel is about 2.5 centimeter behind. So that's an ACL, you can see. So then we place the tibial jig. So once we place the tibial jig here, either we can use a 70-degree arthroscope, or we can make a posterolateral portal look from posterolateral and V, or we can switch over the scope to the posteromedial portal that we had made. You can see here. So the jig is, so this is the medial condyle. So we are looking from the medial side, we have a lateral side. So we have two convexities, and we place the jig in the concavity between the two convexities, and we go as low as 15 millimeter. We make a ream, and we have taken a quadrupled or 5-strand hamstring graft. It should be at least 8.5 or more. And we make then a femoral tunnel. That's from the medial, looking for the anterolateral portal. And we are onto the medial, the jig is through the medial portal. You can see it is about 8 millimeter in front of the cartilage. So that's the cartilage margin. And the jig is about 8 millimeter in front of the cartilage. So when we make a tunnel, we have a wall of about 2 to 3 millimeter from the cartilage. So the idea is that it has to be placed in the strong anterolateral bundle. So anterolateral bundle is always upper part of the notch and the interior part of the notch. So we have a good pull, so that we have a good pull when we pass the graft. So graft is how, this is how with the stainless silver graft is railroaded from tibia into the femur. So that's how the wire is going. So we first put the wire in front, and then we put the graft, so that we don't have an entanglement. So here we are doing a screw fixation. We can use a button fixation also. So we put a screw here, and then finally we put a screw into the tibia in full anterior drawer in 90 degree. So we attain a good step. So that's how the one of the video of the single bundle. So I have one more video of the double bundle. So this is, I wanted to show the full how we take the graft, we dissect the pes fascia. This is a very old video. This is, I wanted to show this technique. This is how we used to do when we started PCL in early days in 2002, 2003. So we take, this is a semitendinosus. You can see it's a unipinnate muscle on one side and the tendon on one side. Then we take a gracillus, it's a bipinnate. We do a routine arthroscopy. So that's an ACL. We have already seen a part of this video. So we do all the diagnostic arthroscopy. So here we have a floppy ACL, nothing else. PCL looks normal. So you can see that's an ACL here. So we debride, and so we used to do lots of double bundles before. I think now with the stump preservation technique, a single bundle, unless until the PCL is completely torn, we can get away with a single bundle with the preservation of most of the stump. So with the more experience in posterior knee arthroscopy, I think we can preserve lots of stump. So here we have created a two points. One is posteromedial bundle. Posteromedial bundle is below and anterior, and the anterolateral is in front and superior. Anterolateral bundle is a more important bundle. So we make 2 points, and so this is one of our older jigs. We make 2 holes into the femur at different angles. So one angle is about 55 degree, the other angle is about 65 degree. So the idea is that we cover the entire stump of the PCL. So we make 2 tunnels onto the femur and the 1 tunnel onto the tibia. So here again for the beginners, though I think with the newer techniques and the posterior arthroscopy is very not that difficult now if you train well. So since during that time we used to make this incision. This is posteromedial. This is well described incision. It's a posteromedial finally safety incision. So the beginners can make this incision as well as the posteromedial portal. So one can be doubly sure where the tunnels are made. So we make a dissect a hole between the gastrocnemius and the posterior tibia, and we feel the we can all feel where the drill is existing, and so while reaming also we can be careful. So we can do this also radiologically under the image guidance. So this is how we used to do before by making the posteromedial safety incision. So the wire is passed, and once the wire is there, we pass 2 threads. So it's a single tibial tunnel and the 2 femoral tunnels. So we have 2 femoral, you can see on a drill. We have 2 femoral tunnels and 1 tibial tunnel ream. So tibial tunnel is ream. So we have taken 2 wires, you can see. So that's how the threads has gone. Now we have 2 threads. So for the anterolateral bundle, we take the semitendinosus tripled and gracilis doubled for the posteromedial bundle. So we have about 7 millimeter semitendinosus and about 6 millimeter gracilis, and we have 2 millimeter wall in between. So 7 plus 6 plus 2, it's about 15 to 16 millimeter of the stump is covered. So we pass both the threads from the femur to the outside. So we have 2 threads now in the femur, separately in the 2 tunnels. You can see these are the 2 tunnels, and 1 in the posterior tunnel. So then we pass the graft. So we pass first the anterior graft, the thicker graft, and then the posterior graft, which is a thinner graft. Lots of chances of suture entanglement in these. So we pass the wire, and then we fix it sequentially. We first fix the 1 graft in the femur, then we fix the tibia in anterior rod, and then we finally fix the 3rd graft of the femur again in anterior rod. So it's basically 1 bundle is fixed in extension and 1 bundle is fixed in 90-degree flexion. So one is for the providing the stability in extension, and the one is for the preventing the posterior, preventing the sag in the 90-degree flexion. So we fix first one bundle in the femur, then we fix the tibia in extension, and then we finally fix the other bundle in 90-degree flexion with full anterior drawer. So this is how we do a double bundle whenever it is required. We can also take a quadriceps tendon, split it into two, and one end in the tibia and the two ends in the femur, and then this is how we can fix with the screws. With the coming of the loops, this technique is very, very easy. We can put a variable sort of a loop on both the femoral side and put a screw on the tibial side. As far as the rehab is concerned, it's very, very slow. We always follow the principles taught to us by Dr. Strobel. So he is very, very slow when the mobilization of the PCL is concerned. We don't give, we give brace for about 3 to 4 weeks now, not for 6 weeks. And partial weight bearing is that or tolerated. And then we start the range of motion after 4 to 5 weeks in prone position, and then slowly we strengthen it like we do in ACL. Thank you so much. I think this is what I have to present. Any questions?
Thank you, Deepak sir. It's really good to see you again in the COVID time.
Somebody
am
has
I
to
audible?
help me stop sharing.
Yeah.
Am I audible to you?
Yes, you are, sir.
I have few questions, Deepak sir. Starting from clinical assessment, how frequently you get isolated PCL injuries? First question. And how you treat them conservatively? How you decide that this isolated PCL injury requires surgery or it's a conservative treatment?
Isolated PCL injury in our somehow in Western world's literature, it is not that common, but what we are seeing in our setup, it is quite common. Patients do come with grade 1, grade 2 injuries. Earlier, we used to operate everyone. Maybe 10 years back, I think, Rajiv, I think we were operating everyone, every PCL. That's a very important ligament one should operate. But nowadays, we are very, very selective. So we do, if it is grade 1 or grade 2, so grade 1 sometimes is very difficult to diagnose. One has to very, very sure, very, very good clinical examination should be done. We have to do a rehab. We have to do lots of quadriceps exercises, proprioceptive exercises for about at least 1.5 to 2 months. So if the patient is still symptomatic, then we go for surgery in these cases. But sometimes, so many times the players come with just they come that they have a competition down the line after 8 months, 9 months, something like that. So sometimes we are coaxed by them, okay, to do the surgery for them because they have already consulted so many. But now our nowadays basically PCL, we are very, very selective on isolated PCL injuries. If it is an isolated, then generally it's grade 1, 2. If it is grade 3, it is always associated with PLC. So if it is grade 1, grade 2, always do a good rehab before one should decide to go for surgery.
Okay. That means that isolated PCL has some conservative treatment role.
Yeah.
Now coming to technique, as always, PCL surgeries are always little bit keep you in a little bit stress because of vascular injuries. My question is, first, how you always you make posteromedial portal, posterolateral portal, and is it sufficient to do surgery with posteromedial portal? First thing.
Yeah,
and
see, it is we do by all the techniques. See, I make posterolateral. Posterolateral is good so we because we are so many times dealing with the PCL avulsions. So at that time, posterolateral, posteromedial portal, working with the two portals become very, very easy to fix these avulsions. And so one should always practice making a posterolateral portal and doing a normal PCL also, because so that when we go ahead with a difficult situation, we know how we are well versed with this portal also. But we can get away with a normal 70-degree scope. If you have a good, the surgeon can really work with a 70-degree scope. We can see the posterior tibia with that. Or we can do also with the posteromedial portal alone. We can put a scope in the posteromedial portal like I showed in this video. it's the scope was in the medial portal and the jig from the anterior. This is how also we can do it. It's all the reference. And
there is one question on the chat box. If you have multi-ligament injuries, ACL with PCL, though we have one case discussion by Dr. Amit sir, do you change your tunnel placement? Just quick answer.
For the PCL, no, I think PCL is always the tunnel is more midline. The ACL, the tunnel is more between the anterior and the posterior border of the tibia. It's the standard technique that we follow. It's only that we change the angle and we change the in a different angle so the tunnel don't collapse.
And one more question regarding the graft. As PCL reconstruction always carry shear forces, which graft you prefer in the PCL?
Hamstrings. Right now, hamstrings. I think we do well with the hamstrings. We can make it.
Hamstring is. Any opinion regarding the peroneus use? Dr. Amit, are you there?
Yes, Rajiv. Yes.
Yeah.
So, I agree with Deepak. If hamstring is available, then probably hamstring is the first choice. But sometimes, most of the time, these PCLs are associated with grade 2 MCL injury also. So if there is some degree of medial opening, I refrain from taking the hamstring. So I sometimes do a quads, and nowadays, as Deepak was also saying, peroneus longus has become, one of my second choice graft at this moment. If hamstring is not available, I'm very, easily I'll go with the peroneus longus, especially if it is a female, if it is a short stretcher patient, this kind of patient, I directly go to the peroneus longus.
Dr. Deepak, in your experience, so vast experience, did you find any vascular injury while doing a PCL reconstruction?
Twice I remember it has happened, and we had a good vascular surgeon to repair, so it can happen. So those were the early days, but both the cases had some adhesions and some surgeries, something was done before.
And then important tips to avoid the vascular injury regarding position, pressure, use of RF shaver, how you
see doing a shaver in the posterior knee scope is very, very dangerous. The shaver can suck anything. And the other thing is you have a multiple ligament injury or some surgery has been done in the posterior or even the posteromedial aspect of the knee joint. Always one should get some CT angio done, so you should know where your vessel is there before you go ahead for in such cases. But in a normal cases, I think the knee should be 90 degree. This is how the knee has to be 90-degree inflection so that the vessel is say about 2 centimeter. It falls 2 centimeter behind. And we should always use a cautery with its mouth paper with its mouth always towards the tibia, and one should not turn the direction towards the other side. One can make another portal where we can put a switching sticks to retract the posterior tissues posteriorly if one is not comfortable. But it should be done under the vision. The tunnel has to be made under vision.
Exactly.
Sumit, you want to ask any question?
No, just one question and one comment. One comment regarding this. Yeah, I agree with Dr. Deepak that doing it under vision is probably the more important thing. Use your ablator to get as much space as you can, as much you can clear out at the posterior aspect before actually going in for the tunnel. Take your time and clear it out so that you can visualize this very well. The question to Dr. Deepak would be, Dr. Deepak, in isolated PCL injuries, do you tend to get a stress view regularly before deciding on surgery? Is that a thing that you use to sort of quantify which one you need to operate or not?
Yeah, we have in such cases we have started using stress views now. It is even for the other ligaments also. Before deciding on to the surgery, we always try to get a stress view whenever we are in doubt. It's important to document also, and important in the when we after the surgery also we can get such views to document.
It gives an objective measure as well.
Yeah, I think Deepak, in some point of time, I also used to do very regularly, especially for PCL, these stress views, but hardly this makes any major impact in my treatment protocol, because whole treatment for a particular patient will depend upon the symptomatology the patient comes with. So,
Yeah, sir.
you know, in some cases you will find out 8 to 10 millimeter of sag, or you know, even grade 3, and the patient is absolutely fine. They don't have any. So probably
Absolutely.
probably for a recording purpose, or for, you know, for academic purpose, yes, the stress use has a major this thing. For those cases, you know, which are doubtful, so you don't know either the patient is symptomatic, or the patient, you know, to go ahead with the surgery or to wait for some time. You know, in those cases, probably the stress views will pay more, rewards to decide either to go for surgery or not. For the regular cases, I don't think this has, in my personal practice, it doesn't have any major impact.
And agreed, sir. In practice, it is difficult to get to the patient to OR and get the city and stress views. Patient compliance and relaxation is, I think, a little bit. It's difficult to decide on stress use. Yeah. And one last question, just on rehabilitation: how you start weight bearing with the PCL reconstruction, Dr. Joshi?
See, we put, as we were doing, Rajiv, before, it is almost the same. So it is a toe touch weight bearing, partial weight bearing for first 2 weeks, and gradually the patient start full weight for about 4 to 5 weeks time. Knee bending. So we, when you were there with us, we used to do at 6 weeks, and then we thought we will do early, so we started doing at 2 weeks. Now even immediately after surgery, then we thought that the PCL starts stretching and we were getting some sag. So now it's something about 4 weeks, 4 to 5 weeks. We start knee bending only after 4 to 5 weeks in such cases.
Okay.
So for 4 weeks, you completely immobilize the knee, Deepak?
Yeah.
So I think my practice is little different, you know. So I allow in prone. What is important to have gaining these range of motion, especially when you are doing multi ligaments. You know, if you are doing a chronic PCL isolated, probably you can wait for four weeks to mobilize. The knee stiffness will not occur. But if it is multi ligament, you are doing in most of the cases I do in single setting, acutely. In this case, stiffness is a big problem. That is why I start early range of motion. And my point is, you can do it in prone. So all the exercises that we used to do in supine for other ligaments, probably if you start doing active assisted or even passive assisted range of motion in supine position, probably the sagging will not occur. And that is what.
That's how, even that, this is how we.
I think we have a little hang from Dr. side.
Now we can have Sumit.
Yes.
Yeah, now you're audible, Dr. Deepak.
I think I agree with this, Dr. Amit, and we have to start it as early as possible. This is how we started. When we started doing at 2 weeks, maybe we started having sag. But definitely now with the better fixation devices, we can always, the idea is to bring the knee back to normal motion as early as possible with the newer fixation devices. I think we can start early, as he's saying, in a prone position.
Now we can have our next speaker on board, Dr. Amit. Please, you can share your screen. And first we will finish lectures and then we will come to case discussions.
So am I audible and my slides are visible?
You are
yes, Dr. Amit. Yes, please go ahead.
Okay, thank you very much, Rajiv. It's always honor to be with you and Deepak. And of course, thank you Biotek also for taking this initiative. Today, I'm going to talk on MCL, probably the darker side of the knee joint, posteromedial structure. At the very outset, it is important to know that even Deepak spoke about PCL. So in isolation, in my practice also, in isolated PCL injury, isolated MCL injury is, relatively rare. It's not extremely rare, but it is relatively rare. So whenever we diagnose a PCL tear, we must make sure that there are other associated injury or not. And similarly, when we diagnose that it is a MCL tear, probably we have to make sure that there are no other associated tears. So, ladies and gentlemen, we all know that we are in era of surgical repair and reconstruction, and whatever ligament we get, we have temptation to repair and reconstruction. This applies and still remains very true for LCL, ACL, meniscus, and probably to some extent for PCL. But when we talk about MCL, so the mainstay of treatment of MCL remains still conservative, and many say that these MCL will heal provided they are isolated. There are various reasons why this MCL heals. It is because of its complex anatomy. If you see this, let me take this laser marker. So if you see this superficial MCL, this is a quite thick structure and then very long, and it goes about 6 to 7 centimeter below the joint line and attaches to the cortical part of the bone, unlike the other structure. In the proximally, it is about 3.2 millimeter above and the 4 millimeter behind the epicondyle, not exactly at the medial epicondyle. So this is the robust structure is the MCL. There is another structure which is in the deeper surface of this MCL, which has been completely covered by the superficial MCL, and this one is known as the deep MCL. Another very important structure, you see that this is a cadaveric dissection of the medial side. If you see that this is a superficial MCL, somewhere there will be a deep MCL. Another very important structure is the posterior oblique ligament, and this is the POL, which is again an important one. And sometime probably you need to repair the POL as well. Many a time we get carried away with the superficial MCL and the posterior oblique ligament. But there is another thing that is very, very important, and probably these are the important things which will decide either we have to go ahead with the surgery or we can still plan a conservative management. That is a semi-membranosus expansion. So this is the semi-membranosus, and it has various expansion. It will go to the POL, it will go to the MCL, even some part will go to the deep MCL. So these expansion of the semi-membranosus will protect these ligaments. So even if they are torn, unless the semi-membranosus is not torn, they will remain in place, and that is why there is a possibility of healing of these ligaments. If semi-membranosus is also torn along with this ligament, probably they will be ripped apart, they will be lying far away from each other, and probably a surgical intervention will be required. So MCL has a healing potential like PCL also, that Deepak was trying to say, because this is an extra articular structure. So even if there is a tear, it will not be continuously bathing on the synovial fluid. So there is a chances of hematoma formation, and they will heal by scarring. So there is a possibility of hematoma organization. That is why there is a possibility of MCL healing. On top of that, there is a multiple supporting structures, and then as I said, there is a semi-membranosus expansion that actually envelops these MCL and the POL. That is why unless this envelope is torn or damaged, these torn structures remains in place, and there is a chances of healing of this MCL. That is why grade 1 and grade 2 MCL tear has very good potential for healing. But there are certain MCL tears which require surgery without any doubt. So if you see this first picture, this is a grade 3 tear, and you can see that the MCL has completely gone away. The superior part has gone up. So this is ripped apart, and then this will never heal. So this kind of grade 3 injury in which the MCL has ripped off, probably this will require a surgical intervention. This is a Steiner-like lesion. You can see that the Steiner-like lesion, this is a soft tissue avulsion from the tibial attachment of the superficial MCL. And why it is Steiner-like is because once it has come out, the sartorial fascia remains intact. So this structure is above the sartorial fascia. So you can see that in the deeper side, there is a sartorial fascia, and this is above the sartorial fascia. that is why it will never go into the bone and it will heal. So that is why it is also known as the tear of necessity. So probably this Steiner lesion will require a surgical intervention at almost all the time. This is another case in which you can see that there is a bony avulsion of the same structure. There is a bony avulsion, and probably these bony avulsion, we have to utilize these, avulsed fragments so that we can send it back and fix it so that a bone-to-bone healing occurs, unlike when we do a ligamentous reconstruction, when there is a soft tissue to bone healing. Another one indication for any time surgical intervention, even emergent surgical intervention, is the MCL incarceration. So this is not that uncommon. Many a times these are missed, and then people forget about or do not address this, and then later on this becomes a very difficult condition to treat. You can see here the MCL has ripped off from its proximal attachment. In distal part it is intact, and the whole MCL has, if you see this soft tissue, this is known as the pucker, the puckering sign. So if you see a pucker sign, probably you have to think that there is an incarceration of MCL, and probably this requires an emergent surgery. And another thing, we agree that probably isolated MCL may not require a surgery, but if it is associated with the multi-ligament, probably most of the time these MCL, which also acts as a stabilizer on the posteromedial corner, probably requires a surgery. So let me, with this, most of these MCL grade 2, like in this case, the entire prostate drawer test was negative. This was a 23-year-old. If you see that valgus, there is a grade 2 valgus stress test positive. So as we all discussed, grade 2 valgus is very much can be managed by, since it is isolated, very well can be managed by a conservative technique. So we decided to manage this conservatively. If you see her MRI, this is her MRI. It was torn almost from mid substance in 2 different levels. This was kind of almost level grade 3 tear, but clinically she had grade 2 when she presented to us after 10 days of injury. And then we managed her conservatively with 4 weeks of supporting brace with the range of motion. And then you can see that after 4 weeks, the knee has completely stabilized. There is no opening whatsoever. Earlier, there was about 5 to 6 millimeter of opening.
It's 17 hours.
But now you can see that there is no opening whatsoever. So this grade 2, as a gold standard, we do not manage surgically. These are very much amenable for the conservative management. So with the aspiration of that, this is another professional footballer of our country, 24-year male, and this is what he had. He also had a negative anterior drawer and the posterior drawer, Lachman test. But if you see that, you can see that the drawer tests were negative, the Lachman tests were negative, good hard in point, but the opening was present. Again, a grade 2 opening in this patient. So both in more in flexion than in extension. If you see this MRI of this patient, his ACL, PCL were intact. If you see that there is a mid-substance tear of the MCL, which looks much better than the lady probably came in the same time. So we again decided to manage this isolated grade 2 MCL tear conservatively. And you know what? After this patient come to us after 3 months, and he demonstrated this magical movement of his knee joint. So you just notice this the dimple and the valgus, So probably the same grade 2 tear we did conservatively very well for our first sportsman, whereas the same grade 2 tear was not good for this this patient. And if you this gives us a very good idea that probably whenever you treat even the isolated MCL, there has to be an individualized approach. You start with the conservative management if it is a grade 2, and then gradually go to the surgical management if it is required. And one thing very important, and then we commonly neglect, is the valvoid knee that many of our patients have. If a patient is having a valvoid knee, and even a grade 2 MCL tear, probably these are the cases which will require some sort of surgical management. So earlier the possible, then there is a possibility of repair. So whenever we see a valvoid knee with grade 2 MCL tear, probably we have to be a very, very careful. Or to say that if you see a MCL tear, you make sure that patient's knees are not valvoid. So if patient is valvoid, even if grade 2, probably the patient will require surgical procedure. So when to intervene, there are two group of thoughts. Some think that early intervention even for the isolated MCL is required. And some people say that probably you have to wait till you identify or till you adjust your conservative management for the MCL tear. So whenever you do early, there are certain advantages and disadvantages also. So early, according to the literature, means if you operate within 3 weeks, that is called early intervention for MCL. If you delay beyond 3 weeks, that is called the delayed. So if you do early, probably you can repair the structures if you can identify those structure well. And if you find that the repair is not very strong enough or good enough, probably you have to augment. So these can be possible only if you intervene. Repair and augmentation will be possible if you intervene early. If it is a late, usually when there is more than 3 or 4 weeks have elapsed after the injury, the identification of structure is not very much possible. So in those cases, probably reconstruction remains the only option for the treatment. There are surgical options available, the repair and augmentation, and the reconstruction. We'll talk about these very briefly individually. As far as the repair is concerned, this repair is very close to the orthopedic surgeons. We keep on repairing all the tendons, ligaments, and of hand and feet. So that is why whenever we find a repairable structure, many of us, we tend to repair it. And then theoretically speaking, repairing will preserve the normal tissue. So we'll have, certain good theoretical outcome. But if you go to literature, which is done by Brian Wolfs in 2019, they say that there is a higher incidence of arthropibrosis, about 19 to 45% if you go early intervene and do a repair. And then there is a possibility of 40% failure rate of repair. So since high chance of failure rate of repair, if you allow early movement at the repair site, probably the failure rate is also very high. That is why not very people nowadays do repair only. That is why it has to be augmented with certain structure. Some people augment with the fiber tape or some other artificial ligaments. I augment with the autologous graft itself, the hamstring graft I use for augmentation. So the augmentation along with repair allows early mobilization. That is why the stiffness will not occur. Augment will protect the repair till the time of the healing, and even the literature says that it has a very good outcome. So rather than repairing alone, probably it has to be augmented whenever possible. But this technique is not useful in chronic setting. And then problem associated with the hardware or the cost, the tape, the artificial ligament, they are not very cheap in our context as well. So this is one of the drawback of the augmentation. Reconstruction, probably one of the most talked about at this moment, the medial side reconstructions. And then literature also says that reconstruction has the best predictive outcome. There are various methods of reconstruction, the single bundle, the double bundle, non-anatomic, double bundle anatomic, which is popularized by Laprade. There are various techniques available. This is probably at this moment the most gold standard one, that is a Laprade anatomic reconstruction, in which he uses one part of the graft to reconstruct the superficial MCL, and the other part is the posterior oblique ligament. But if you see that there are certain drawback of these technique in Nepal, even in India, these our femurs are very, very small. And as I already said that these are usually associated with the ACL or even PCL injury. There are chances of tunnel coalition, chances of making many perforations into the into the femur, which will weaken our fixation devices. So it requires 4 tunnels, 2 up and the 2 down, 4 tunnels. So if you use 4 tunnels, you need 4 implants also, so it is very costly implant for our context. And then many of our patients, they do not afford, especially if it is associated with ACL or even PCL injuries. So the cost is a big issue. The tunnel coalition is a big issue. In my context, if you use even the same size screw in the tibial part of the superficial MCL, there is a high chance of cutout. So this is one of the main problem that we had in our practice. Another technique, this is a Kim's technique, in which you take the semi-T. Sorry, you take semi-T, do not detach it from the tibial side. You attach in the epicondyle at the anatomic location and then reconstruct the POL. And this is the Kim's technique. It will have only 2 tunnels, one in the femur, one in the tibia for the POL. So chances of tunnel coalition is also less, and the cost effective as well. But this is the problem with this one, is this is a non-anatomical. If you see that MCL is vertical to the joint line, whereas this goes oblique, and this will not provide, and this will not be even the isometric. So if it is not isometric, there is a possibility of stretching out. That is why Kim's technique, even though it is used very commonly, but there are some darker side of these technique as well. So in 2019, we published our weave technique, which is essentially a modifications of Kim's technique, in which what we did was we kept the semi-T attachment intact. Then we weaved through the remaining part of the superficial MCL, which is attached in the tibia. So that is why it is called a weave technique. So if you weave it and suture it into the underneath the tunnel, soft tissue tunnel of the superficial MCL, then it will acquire the same direction of the superficial MCL. So now it is not coming from this side, which is in certain angle, but this is just parallel to the MCL. And you fix it into the femur at the anatomical position, and then bring the other limb back and fix it into the POL position. So this way you can same technique in which the distal part is remained attached, and you don't need any tunnel into this cortical bone, but you still use the semi-T and reconstruct the anatomic MCL reconstruction. This has been published. I'll just like to play this video, which has been published in an Arthroscopy journal. This is a 4-minute video. I'd like to request you all to watch this. We are going to demonstrate a new technique of anatomic MCL and POL reconstruction, MCL weave technique. We have nothing to disclose. This technique has 4 distinct steps. Step 1, semi-T harvest and preparation. Step 2, graft weaving. Step 3, femoral fixation. And step 4, POL reconstruction. After the skin incision, the pes inserioris is identified. A longitudinal incision is given in sartorial fascia along the upper border of semi-T, and it is delivered into the incision. The semi-T is isolated from interconnected band and vincula. It is harvested using an open-in stripper and sutured with finger trap technique. Then the footprint of the MCL is identified. 2 longitudinal incision was given at the footprint of MCL as described in the text. Now, using a mosquito forceps, a soft tissue tunnel was created from the anterior incision to posterior. A suture shuttle was used to pass the semi-T through this soft tissue tunnel. A care is taken not to twist the graft when it is passed underneath the MCL footprint. Few absorbable stitches were applied at the upper edge of the incision to attach the graft with native MCL. Once the semi-T has been weaved, we can appreciate the change in course of graft before and after weaving. Then the incision is extended up to the medial femoral epicondyle and it is exposed with a longitudinal incision. In the position of the bead pin, the graft is shuttled up into the femur underneath the sartorial fascia. It is looped around the bead pin. A marking was made and the isometricity was confirmed by putting the knee into its full range of motion. Once the isometric point is confirmed, the graft is looped around itself and whip stitched for about 2.5 centimeters in order to tubularize the graft. Graft is sized. A 40 mm long tunnel of same size of the graft diameter is made. The graft is pulled into the tunnel and fixed with one size bigger diameter biodegradable screw at 30 degrees of knee flexion. Then the remaining end of semi-T is again shuttled down to tibia through the same subsartorial plane. Direct arm of semi-tendinosus is identified at posterior medial border of tibia. A point just anterior to the direct arm is marked and a bead pin is inserted through this point towards the Gerdy's tubercle. A 6 mm diameter tunnel is drilled. The length of the tunnel can be adjusted depending on the remaining length of the graft. The graft is pulled into the tunnel and fixed with 7 mm bio screw at 30 degrees of knee flexion. Now we can appreciate the final reconstruction of MCL and POL. So to conclude my presentation, probably when we deal with MCL, there has to be an individualized approach. There are so many things we have to take into consideration, especially if the patient has a valvoid knee. Even in grade 2 MCL tier, the patient will very poorly tolerate. So that has to be taken into consideration. If we can intervene early, we have to do a repair with augmentation. Probably repair alone have shown that the results are not that very good if you start early mobilization. If you immobilize for very long, stiffness is a major problem in those cases. If it is a delayed case, probably MCL reconstruction is the main treatment modality that can be given. There are various techniques of reconstruction has been described in literature, including ours, but choice has to be made considering many factors: the cost factor, the size of the femur, either it is an isolated one or it is associated with some other ligamentous injury. Thank you very much. Thank you. I've done with my presentation.
Thank you.
If you have any questions.
Thank you, Dr. Amit. Thank you for such a lovely talk. It was a very detailed talk and a very lovely technique, especially in our scenarios where implant costs and the femoral morphology play a very important role in choosing the grafts and tunnels. My question is that do you repair the POL in all, reconstruct the POL in all MCL reconstruction cases essentially?
This is a very important question. This is based upon my clinical examination. If the patient is opening up in full extension, so that means the POL is also gone. So
yeah.
If there is no opening in 30-degree of flexion only. So probably you can get away with doing only MCL part of the reconstruction. But if it is opening full extension, which is usually happens, if the patient is not opening in extension, the patient will be very asymptomatic. So the deciding point is if the patient is opening in full extension, I do both MCL and the POA.
And usually, I mean, again, as you've already told about that, it's a very nice thing, and you have to take case by case. But generally, let's just talking through your data. Do you get them early or do you tend to get them late? Apart from the seniors and the avulsions, that's a different category altogether. But let's say grade 2 or grade 3 tears.
I understand. Unfortunately, both in Nepal and India, these people come pretty late, especially if it is an isolated one, even if it is a Stener lesion, even if it is an avulsion, the general orthopedic surgeon will see that and say that, oh, there is a small piece of bone which is extra-articular and probably they don't require any treatment. So these patients definitely come late. Unlike the multi-ligament injury or knee dislocation, if it is associated with multi-ligament injury and the knee dislocation, these patients come pretty early to us. But isolated, very rarely they come early to us. Usually it is late presentation.
Thank you, Dr. Amit. As always, your lectures are really wonderful and with clear, precise messages. My question, if regarding your technique, if there is a MCL avulsion from the tibial side, there is no footprint, no remaining stump, and then how to weave this semi-teak through that?
You caught you hit the very sweet spot, Rajiv. So for this weave technique, you need intact tibial insertion. So if it has been avulsed from the tibial side, probably you cannot do a weave technique. Either you have to do the Kim's technique that I usually do, and or even the Laprat's technique, which is required.
In that case, you recommend to put a spiked washer and then reroute it so that we can make it in line with the superficial MCL. Do you have any comment on that?
If I can reroute the superficial MCL, if I can identify like Stener's lesion, if I identify.
No, I am talking about semi rerouting with the spiked washer, make it straight in line with the superficial MCL.
Very, very good. This has been mentioned by, I think, Mushal, Volker Mushal has, Volker Mushal has published his technique of rerouting. Is he doesn't put a spike, he puts an anchor onto the tibial attachment, and then he ties over that anchor so that he reroutes the semi-T towards this thing. This can be done, but probably in my opinion, just attaching with the anchor may not be that much stable, so I do not do that. I agree, maybe putting a washer there is a very good idea, but if you put, you see that the superficial tibial attachment of the superficial MCL is very superficial, it is subcutaneous. So when you put a washer and the screw out there, they become very much palpable.
They always impinge on the skin.
Yes, and then the patient comes with irritation and so many kind of things. But this can be done. This can be done. I usually do not practice. In one case, I made a, on the medial border of the tibia, I made a bony tunnel. So in my weave technique, I do a soft tissue tunnel or the periosteal tunnel. I go underneath. But if it is not available, you can make a small bony tunnel, and then it doesn't require any fixation. You just pass through the bony tunnel and then pull it up. Probably that will also.
Referring to one of your slide in that you mentioned that arthrophyrosis if you combine with the ligament MCL with other ligaments. In your practice, if you get MCL with ACL injury, would you like to do always in 2 sitting, or is there any indication in that you go with the single stitch?
My primary practice is single stage, even for multi-ligament injury, even 3 ligament I have done, even in 4 ligament, I do everything in first setting. Because if you get them early, many a time you will find out that these are not, the remnants are preserved, and these are avulsion either from the distal tibial side or from the fibular side. So you can take an opportunity to repair it also, when you're talking about ACL and the PCL.
Even if you get the patient within 7 days?
Yeah. Even in 7 to 8 days time, that is my optimal time. I go ahead with the primary. Many people, even the literature says that there is a chances of extravasation of the fluid and then this thing, but around 56 cases of acute intervention. If you want me to show that, if you harvest your graft, if you give an incision on the medial side of the knee, which is extendable for the MCL reconstruction, all the fluid will not go into the calf. It'll trickle out from the incision that has been given.
Any fear of stiffness?
That is what I was talking to Deepak. There is absolutely well proven fear of stiffness if you do in acute setting. That is why probably I put the patient into a hinge brace and start early range of motion. If I have reconstructed the PCL, I do all the exercises in prone. If I have done ACL and the PCL, I haven't done anything, probably I'll do all the exercises in supine.
Is there any literature supports that if you have bruise on the medial side of the knee and you have bone marrow edema on the MRI, and then chances of arthrofibrosis is more, as you find in your practice that bone marrow edema on the femur tibia is really matters a lot regarding the stiffness post-operative rehabilitation of patient?
I have not. I have read some literature who are mentioning that bone marrow edema probably has to be subsided to some extent, so that it is not because the patient will develop stiffness, because the hold, if you put a screw for fixation, because of the softness of the bone, because of the edema, the hold will be less and there are chances of failure, but not with the stiffness. But if there is a massive bone marrow edema, probably you have to wait for some time before you intervening. But you can very well come within 2 weeks time. Wait for 2 weeks time. If someone is having very massive edema, I have waited for 2 weeks time. I'm done in the single setting. So good. A very common problem. If the patient develops stiffness and in 6 to 8 weeks time, if patient doesn't come up with the physiotherapy, I think the patient to theater, do a gentle manipulation, and then 6 to 8 weeks time it can
Dr. Deepak, your comment on this regarding the acute MCL and ACL reconstruction altogether?
I think as very rarely patient comes the day 1 to our center, they are always managed somewhere. So if the patient comes on day 1, definitely if there's a multiple ligament injury, then we have to, generally we do in one sittings and we do all the 3 ligaments together, and we tend to mobilize them early, as he's saying, to avoid stiffness. Regarding the bone marrow edema, I have not come across with any such situation, probably because the patient always pay.
Amit, in your all well-fixed MCL reconstruction, repair, augmentation, still, if you find some laxity, how much you accept that in follow-up, that is grade 1, grade 2 is still giving way, how much you accept in your football players, what you showed us?
This is very tricky question, Rajiv. So you try to achieve good stability intraoperatively. So you make sure that intraoperatively you have achieved a very good stability. The valgus opening is good. Once you have achieved a very good stability intraoperatively, and then post-operatively you find out that the patient is going to have a grade 1 or even sometimes grade 2 valgus opening, so probably you don't need to do anything. You just watch what are the signs and symptoms, or how the patient develops. If the patient doesn't have any severe complaints, probably you can just manage even with the grade 2.
My question to both of you, because you are the two best arthroscopic surgeon, I know them. Looking at in Indian scenario and patient population, in whether it is a PLC or it is a MCL, do you recommend, do you find Laprade technique with KIMS with a single, do you really think that Laprade is wonderful and it's doesn't stretch out in the future in the follow-up? What is your
I
take
think
on
Laprades do stretch as with any other technique that Dr. Amit has shown. Every technique, Laprade also can stretch up. But the problem, as he told in our scenario, I, for the medial side, I have not done Laprade any time, because I have used the same technique that he has used, like we harvest from the medial side. But I tend to use staple. We can put a small staple to redirect the direction of the MCL, superficial MCL. The problem is that MCL is generally associated with some other ligaments, and making so many tunnels in a very small tibia of our patients sometimes become very difficult. But these techniques do well. For the MCL, I have, it's very rarely after MCL the patient comes and tells that she's unstable, and most of the patient, I think 90%, more than 90% of the patients with this sort of a triangle technique do very well. And Laprade I have not tried, never tried on medial sides. Again, problem is that so many tunnels, it is very difficult. I think Amit can comment on.
Yeah, I absolutely agree, Deepak. Laprade's technique is very good when the condyle is very big, and then probably if it is purely isolated MCL grade 3 for some reason, which is extremely rare, or your PCL might have healed very perfectly, whereas MCL has not. If there is a very big opening in medial side, probably you can do a Laprade technique. Why Laprade technique is lucrative is because this is called an anatomic technique, and it nicely reconstruct your superficial MCL, and then if you put an anchor at the tibial attachment of the deep, that Laprade does, it reconstruct your deep MCL as well as the POL. That is why it is more lucrative. But there has been no comparative study between even Kim's technique and the Laprade's technique. Probably I'm happy with my patient with our own modification, or even the Kim's technique was not that bad with me when I used to do along with the multi-ligament. So in multi-ligament setup, probably Laprade technique is a big no for me. I usually do not do. Only in a very elite sportsman with gross valgus, I do the Laprade technique. Very few.
I think that's the key where Dr. Amit, last thing that he said, that elite athletes and isolated MCLs. I think that's the key. Where we're looking for really high-end performances, that's where probably the Laprade would maybe make a difference. For general population and our general clientele or the patients that we have, I think Kim or the any modification of a weave actually works perfectly fine.
Thank you. Now my talk is on posterolateral corner. Most of the part is covered by Dr. Deepak. What is anatomy is again important as MCL. What Dr. Amit described, we have on the lateral side is convex lateral femoral condyle that articulate with the convex lateral tibial condyle. That's make it unstable as compared to medial compartment. That's why PLC injuries does not heal by itself as compared to MCL. We have, as all we know, that we have fibular collateral ligament, we have popliteal fibular ligament and popliteus tendon that are important structures on the lateral side. We have lateral gastrocnemius ITP band on the superficial layer. As all this dissection, as already we discussed, Laprade everywhere on the posteromedial and posterolateral side. This is a relationship what he in the cadaveric dissection around 18.5 mm the distance between the femoral fibular collateral ligament on the femur side and between the popliteus tendon. That's why the critical structures for the posterolateral corner is fibular collateral ligament, popliteus, and popliteofibular ligament. These are three critical structures for stability on the posterolateral corner. This is what already discussed. If we have varus valgus opening at 30 degree, that shows that we have collateral ligaments. If we have 0 degree with varus valgus opening, we have combined cruciates. And if we have external rotation at 30 degree, more external rotation on tibia at 30 degree, that shows that posterolateral corner. If external rotation is more in the 90 degree, that shows that PCL and PLC is there. This is what we discussed in the first lecture. This is if you have more than 12 mm, that shows that you have combined PCL and PLC as compared to grade 1 and grade 2. This is what PLC you have to be a little bit cautious while examining your ACL, because we all know that ACL is also combined with the PLC injuries. You just have to have in your mind that if you have drive-through sign while doing ACL, you have drive-through sign that think that there might be a probability of PLC injury. Use stress x-rays, but it is difficult in day-to-day practice. And always look for the peroneal nerve function if you are suspecting any PLC injuries. This is what already discussed in first speaker. This is what if you have side-to-side difference more than 2.7 mm, then it is a fibular collateral. It is a more than 4 mm, that shows that it's a complete posterolateral injury. Yes, MRI, it requires specific section with thin slice. You can easily find out about the fibular collateral ligament biceps avulsion on the coronal section. Of course, a scanogram is always important in the chronic posterolateral corner injuries, because if you miss that alignment, then your repair going to be fail in coming days. The options, if you have if you have chronic posterolateral corner injuries with varus thrust, then might be you have to go for with the open wedge STO. And some literature says that if you correct the slope at that time, you can you don't require any combined PCL reconstruction as well. This is what drive-through sign is very important while going looking at your lateral compartment. It can be with ACL injury also, and of course it helps you in diagnosis of whether that lesion is on the femoral side and tibia side. This is what if you missed your PLC injuries with PCL reconstruction, then the PCL graft is going to fail in the coming days. Always look for posterolateral corner injuries while doing PCL fixation. Regarding preoperative, of course, the physical examination and stress x-rays are important. How you choose your graft, it can be we use Symposium and gracilis, depending upon what type of method of reconstruction I am using. If you have acute injuries, of course, you have the chances of repair with augmentation as like MCL repairs, and always because there is an involvement of peroneal nerve injury. If you require if there is a involvement, then do neurolysis, and augmentation is always there, because in the acute injuries the tissue is fragile, they get stretched out. Augment with the Symposium and gracilis, or you can use the fiber tape also. If you have a chronic posterolateral corner deficiency, again options are delayed primary repair, difficult because the ligaments and the tissues get shortened and fibrosed. Of course, there is some papers on advancement of popliteus, LCL, and gastroarterial complex, but autograft reconstruction is again a method of choice. All we have fibular based reconstruction, starting from the Larson. This is the most common and first described figure of 8 using a single tunnel and this two tail of grafts on the fibular side. The problem with the Larson was that it was isolated, it got stretched out with the time. Then comes this is what this video I got it from Dr. Deepak. Sorry, it is not working. Now that comes the Laprade anatomical reconstructions. It is a fibula and tibia based reconstruction, and both he reconstructed FCL, with popliteal fibular ligament and popliteus tendon. The same discussion, the bony, if you have combined ACL, then you get your femur size is not so big that you can place 3 tunnels in the femoral condyle. And again, the problem with the graft length, because we don't have availability of allograft, we have to use the all the autografts. This is how they made one. This is popliteus tendon. This is popliteal fibular ligament, and this straight goes to fibular collateral ligament. This is how the anatomical reconstruction by the Laprat. Again, what is my choice? I do this Arthroscopy type PLC reconstructions, in which there is a single fibula based tunnel with the same graft, one at femoral insertion of LCL and one fixation at the popliteus insertion. This is what this is a hockey shaped incision. This is the peroneal nerve. And you require SIAM to image intensifier to see your location of the tunnel, proposed tunnels. And what is required is around 18 mm average, 14 to 22 mm distance is required depending upon the patient profile between the 2 tunnels. And one is this is in the popliteus hiatus. You can expose, or you can use SIAM to put your this between over there, and this is over the lateral, just posterior to lateral epicondyle. This graft semity in the fibular tunnel, and you just go deep to the ITP band, and one fixation is there down over the popliteus tendon, and this is for the fibular collateral ligament, and you fix with any bio screws. Again, rehabilitation, of course, I tend to keep them slow rehabilitation with the PCL and PLC, keep them non-weight bearing 4 to 6 weeks. And I start range of motion depending upon the fixation and bone quality at after 3 weeks. And of course, all the heavy exercise after 2 months. As we all know that fibular collateral ligament, popliteal fibular and popliteus tendon are the main static stabilizer on the posterolateral corner of the knee. If you get the patient within 2 weeks, within 3 weeks, you can think of repair with augmentation. If your patient is old with old injury, always get the scanogram to see the alignment, because if it is a varus, then your posterolateral corner repair reconstruction going to fail. ACL injuries can be associated with the PLC also. PLC injuries, always keep in mind while doing ACL reconstructions. And anatomical PLC reconstruction, if your patient is of high demand, they are contact athletes, go with that. And in my hand, this Arthroscopy technique is good with good outcome. Thank you. Thanks for your time. Patience hearing. Now, my question to my faculty, what is your take on regarding the PLC reconstruction? What their choice for their patients? Starting with Dr. Deepak.
I think it was very nice you have shown this, Rajiv. So we do both Larsen as well as the Laprat. So Laprat, on the lateral side, I do Laprat quite often. So if it is a dial test is positive and we have a lateral opening, then we go for a complete anatomical Laprat. And if it's an isolated LCL, then we go for a Larsen technique.
Absolutely, I absolutely agree, and then reiterate the fact that clinical examination is very, very important. You try to identify clinically what are the structured tone, you know. If your popliteal fibular ligament or the popliteus tendon is intact, there is no point reconstructing that. So many people keep on thinking that Laprat's technique for lateral side, Laprat's technique for medial side is, you know, for every cases. It is not that. You identify what are the structure that has been turned and try to reconstruct. So the advantage of Laprat's technique above the Larson's, modified Larson's, the figure of 8 or RC technique that Rajiv said is the popliteal fibular ligament. So even the modified Larson technique will reconstruct the popliteus and the lateral collateral ligament, but it will not reconstruct the popliteal fibular ligament, which is very important to identify by the dial technique, the dial test. If the dial test is significant, if it is borderline, probably I'll still do a modified Larson. If it is a significant dial test, probably Laprat test. The Laprat technique is the way to go.
Do you use nowadays with fiber tapes and ultra tapes with your grafts, autografts?
Not me, Rajiv. I think we have talked.
Yeah, for some reason, if I'm okay with the autograft, I don't want to put any foreign material because they have their own complications. If I have good size graft, if graft is good quality, I do not use augmentation tapes and fibers. But if the graft is not good, if my fixation is something, if some problem, only very few times, it is not my standard technique of using augmentation with the tapes.
Can I go back to regarding your Dr. Amit? If you get a multi-ligament injury, high energy trauma with unstable posterolateral corner, how you manage with the Laprat graft? How you manage your graft with the Laprat technique, with PCL reconstruction, with ACL? How you use both limbs for the graft harvest?
You see, Rajiv, my first choice is I will try not to touch the normal leg. If there is not possible, if I have to harvest, then I'm not hesitant to harvest also. But many a time, if it is even the 3 ligament reconstruction, you can very well get away without, touching the other side. You can harvest the quads, you can semi-T, and then gracilis, and then the peroneus, and then you still have a BPTB which can be used, So there are 5 grafts, so you can utilize based upon which is best suits for that patient. And then touch wood, for last 3-4 years, I have not gone to the other leg unless it is a revision case. In primary case, probably the same leg graft is.
If you have any multi-ligament case, we can discuss on that. You want to show, Dr. Amit?
Yeah, I have kept one case. Let me find it out first. So let me share the desktop. Okay, wait. Let's hold on. I think I'm having something here. So close this first.
I think, Rajiv, with the peroneus coming up in last few years, I think earlier we used to always touch the other leg, and with peroneus coming, and we do tend to manage if we have 2 or 3 ligaments the same leg.
Deepak sir, what I think in PCL, if we use peroneus, chances of stretching out is less as compared to hamstring. And if you feel the rigidity even after in that second month, you feel just a rigid fixation. I think we should think over that using of
as a primary graft. You are saying,
yeah,
maybe there is one study that's going on to use it as a primary graft. So that's what we are doing.
I think there are publication also, peroneus longus as a primary graft, and they have shown good results. But having said that, whatever new comes, to tell you very frankly, peroneus longus is my favorite, and I do not hesitate to go into, if I'm doing a ACL along with the PCL, for PCL, peroneus longus is my first choice of graft. So rather than going into the quadriceps, I go to the, peroneus longus. But time will tell us which is a good one. And this is good that we practice different stuff so that we can have a comparison of each other's experience. So let me share, Rajiv, a very short case of a multi-ligament. This was a 45-year-old gentleman, fall from 20 feet height, 7 days back, and then he was managed in local area. Patient says that there was no obvious dislocation, but there was a bruising. I'll show you a picture of that patient, bruising and all. The patient was not able to weight bear on his same leg. And then he was referred to us. The patient presented after 7 days. This was his MRI. His MRI, I don't know if it is clear. I don't know. You can see that there is a ACL tear and the PCL is not visualized here. So there is a complete ACL and the PCL tear. Again, the same T1 sagittal section. There was an MCL tear. This is important to see that the MCL is a grade 3. And you see that this is the part of MCL which is supposed to be somewhere here, has gone all the way up. So this is never going to heal, this MCL. So that's what, that was a grade 3 MCL. If you just notice that the MCL is ripped apart and it has gone all the way up. So there was tear of the MPFL as well, but the patient was not very much, subluxating. His patella was not subluxating. This was his clinical. This is the clinical examination. You can see that bruise on the medial side. This is after 12 days. Rajiv was asking, I don't know who was asking after how many days it is safe. This was after 12 days. You can see that anteroposterior instability was quite obvious. I will ask you definitely at some point of time after this clinical examination. So ACL PCL was torn, and then you can see that grade 3 opening of the medial side. So how to go ahead with the patient has already undergone MRI examination. So Rajiv, so let's start from you. What you do next? You want some more investigations, examinations?
We have a clinical, we have MRI, and
yeah,
in this multi-ligament injuries, I just want one regarding the vascular part also. For and any hidden vascular injury or any occult thrombus on the popliteal part, if it is a fresh one. If it is an old one, there is no issue. And
this is
one more
11 days after the injury.
Then I must go for CT angio.
So in all ligament injury, you do CT angio?
Yeah, if it is it's a multi-ligament, 3 ligaments enrolled, and if it is a fresh one, because I have encountered one patient with late onset vascular gangrene because of intimal thrombosis. Okay. That's why nowadays after that I decided to go with this CT angio and all this multi-ligament injuries. If it is a more than 2 to 3 weeks, there is no issue. But if it is a less than 10 days, I go with the CT angio.
So Deepak, what is your take on this?
My personal opinion.
Again, clinical examination important. If we have a doubt, then only we go for a CT angio. But definitely, when the patient comes acute, we do measure an ankle brachial index. If it's fine, I think then we don't go for the CT angio. In such cases, if we have good pulses and everything, generally we don't go for it. And I think in such cases, I hope that we have done everything, all the X-rays and everything. They are absolutely okay. And then the plan is here that we should do an MCL number 1 in this, and we should try to do a PCL. So PCL and MCL, I think, are the 2 ligaments that we must reconstruct, and the MCL has to be augmented. We cannot take the hamstrings on this side, on medial side, because of an MCL. So we have to leave the hamstrings of this particular side. So that is how the plan of action, and if possible, generally we do an ACL in the same sitting.
Okay, Dr. Banerjee, what is your take on this? How do you first let's talk about angio, CT angio. So Rajiv said that if it is 10-12 days, he'll definitely do a CT angio. Deepak said that he'll base up his further investigation.
For the CT angio, I agree with Dr. Deepak's perception. We'll go for an ankle brachial index in the acute cases, and if that's fine, we generally don't do a CT angio for every case. As regards to the reconstruction, again, I would probably agree with Dr. Deepak. I would do the MCL and the PCL. I would personally, my opinion, in these cases, I tend to do the MCL and the PCL in first setting and then do the ACL in a second stage, as a second stage procedure. For the, in terms of the graft choices, again, I think I use the quads, I would use the quads and the peroneus in this case.
Okay, so I think we have jumped a little bit and summarized. My question was CT angio is a very important thing, and there are clearly two schools of thought worldwide, and here also amongst the panelists there are two schools of thought. Right, that he will definitely do. If the patient comes to him 10 days, 2 weeks, he'll do a CT angio, and then probably I also do not do CT angio for all my patient, but ankle brachial index, also very, very important. And if you go to literature, this is the tool that probably Europeans will justify the need of the CT angio. So ankle brachial index is a very important tool, and I utilize them very judiciously. And the clinical examination. So suppose this patient came to me after 10 days, there is no whatsoever swelling of the lower limb or edema, so the feature of vascular compromise is not there. Having said that, Rajiv pointed out a very important, aspect that intimal injury, small thrombus will not be detected even by the, ankle brachial index. And then important thing is this small thrombus may not be detected by the CT angio also, because you don't know when this intimal tear will enlarge, and the small intimal tear will not be visible in very, very early done CT angio also. So it's all two-way sword, but probably to keep you in a safer side in some cases in which, this kind of gross instability, if the patient gives a frank history of dislocation, probably doing a CT angio is also not a bad idea. But personally, I didn't do CT angio for this patient. The patient came to us after 10 days, and then on examination, probably the patient doesn't have any ankle brachial index abnormalities, and the clinically also pulses were bilateral equal. That is important to know. Bilateral equality. Probably you'll put a Doppler to see that either bilateral equal, pulsation is there or not. Maybe that is how I go. Rajiv, you want to add something, or I'll go into the treatment plan? I will ask.
You go ahead, sir. Just in doubtful cases, you find that there is a gross instability. I think it's a safer way for documentation, because if you are going to put a tourniquet, and this multi-ligament injury surgery is going to be for 2.5 hours. If you have any doubt, gross instability, because sometimes the clinical examination regarding the vascular part is difficult for assessing whether what is happening in the posterior aspect of knee. We should keep in mind regarding this investigation also.
Okay, absolutely agree, Rajiv. So suppose given for you angio is normal for this patient, so you'll go single stage or double stage?
I'll go single stage.
Deepak?
I think I'll also go single stage.
Okay, so Dr. Mukherjee, you'll go 2 stages?
I usually go 2 stages. I can, but I usually go 2 stages.
So suppose, okay, 2 stage you said that you'll do PCL and the MCL. So Deepak, so what will be your graph for MCL, PCL and ACL if you are going with a single stage?
So I think I'll use the quadriceps, the peroneus longus, and the hamstrings. So these are the 3 graphs. For PCL, I generally use then peroneus longus. And for ACL, I use the quadriceps tendon, and the hamstrings is for the MCL. Now the issue here is whether we take the same side hamstrings or not for an MCL. But I think when we are doing an MCL, we generally take the same side. Same side semi-tendon also generally we take. If we are doing a repair along with it.
Absolutely. Rajiv, your take on
MCL, we are trying to treat conservative, then we don't take the hamstring from the same side.
Okay. Yeah, that is absolutely, that is important. If you have conservative management for MCL, probably hamstring has to be preserved on the same side. If you're going for surgery, probably there is no point saving the same hamstring. Rajiv, your take on grafts,
almost
please?
same as Dr. Deepak. Peroneus nowadays, peroneus for the PCL, hamstrings for MCL, and of course with quadriceps, quadriceps for the ACL, and fixation, of course, first PCL. If it is a PLC, then PLC, then ACL and MCL. This is how I fix in this way.
Absolutely. So I think we have already discussed that is how it's coming. So this is the quadriceps that has been harvested that we did. So important thing is I do not apply tourniquet when I harvest the grafts, because that will preserve my time, because as Rajiv was also saying that it's going to take about 2 hours for reconstruction of all these 3 ligaments. So harvesting of the graft is without tourniquet for me. I use a little bit of adrenaline to harvest the graft. Maybe sometime to do a quick diagnostic arthroscopy, I put a little bit of adrenaline inside the joint also, if it is about 2 weeks, 10 to 12 days old. This is the peroneus that I have used for the PCL. This is PCL reconstruction. Unlike Deepak, I go, I do usually a single bundle if it is a multi-ligamentous, conditions. If it is a isolated PCL, probably I do a, only double bundle. But most of the time, in setting of multi-ligament, my PCL is a single bundle, and this is how the ACL goes, which is a quadriceps. And then Deepak was saying that since this is only 12 days old, I did a repair of the torn part, the medial structure. This was all avulsion of the semi-membranosus complex was avulsed. So I repaired that. The posterior capsule was also repaired from, and then if you can see that I use the same side hamstring semi-T only for the augmentation of that repair. So I do not do a use of tapes or something. And this is at 3 months follow-up of the patient. You could see that very much stable knee joint. There was a little bit of flexion restriction, but in 3 months' time, I do expect with the 3 ligament injury, and then in 6 months' time, I do not have his follow-up, pictures, but in 6 months' time, there was full range of motion of this patient. You can see that very rigid valgus and the varus stability. And this is how the patient is walking in 3 months' time. The patient was very happy. Thank you very much. Rajiv, this is my case. If someone else has case, we can discuss.
I have one also, but this is really
15 hours
ligament injury with a good range of motion, because the stiffness is one of the biggest problem with all this multi-ligament injuries. And how you rehabilitate, just fast few tips, how you rehabilitate them. And one more question, is there any DVT prophylaxis in such type of patients?
Rehabilitation, as we have been, we have been talking about, I'm very aggressive when rehabilitation. I provide hinge brace for all these patients to stabilize valgus varus. If it is a PCL reconstruction, I do not have a posterior tibial brace, posterior PTS brace, but I use a pad just underneath the calf so that it acts as a PTS and then puts your PCL forward. But the patient is in brace. With brace, the range of motion is achieved as soon as possible. Maybe in 2 weeks' time, I would love the patient to have more than 90 degree, at least 90, 95 degree range of motion. And then once the patient has crossed 90 degree range of motion, then we can go gradually slow. Weight bearing is avoided for 4 to 6 weeks' time, but the range of motion I will achieve as soon as possible in that patient. DVT prophylaxis is a very important, and then we are trying to revise our protocol of DVT prophylaxis. To tell you very frankly, till date, we do not use a DVT prophylaxis, chemical prophylaxis. We do a mechanical prophylaxis only. And the patient is up about moving his ankle and knee right from 3rd day of the surgery. So we do not use at this moment chemical prophylaxis, but mechanical prophylaxis alone. Rajiv, do you use, and Deepak, maybe Dr. Banerjee also highlight use of DVT prophylaxis for these patients in multi-ligament injury?
Not till date. Not till now. No.
No, I have
But
not.
No chemical prophylaxis.
No chemical prophylaxis.
No chemical prophylaxis.
I've never seen a DVT. I have seen one incidence of DVT, that too after an ACL reconstruction, where we had mobilized him early. Really, I don't know how it happened, but we had seen done by some other surgeon, but I had seen one case of DVT till date.
This is very important, Deepak, because maybe this patient wouldn't have come to us. They were, minimal symptomatic. We could have neglected it.
Yeah.
One of my fellow has started a research on identifying the incidence of, these DVT in patients of ACL injuries. Literature says it's about up to 7%, asymptomatic about 35% of these people may develop. So this is a very sensitive thing. To my, surprise, only few high-risk group of people, especially the doctors, if you operate on them, they are very prone for developing complication. So I still remember two of my doctors, developing DVT, one after ACL reconstruction, the other one after, just minisectomy, the patient had developed a DVT. And then there was another
the
one.
VIP. That's the VIP syndrome at play.
Yeah. Another one was not VIP. He actually developed a pulmonary embolism, and then pulmonary embolism secondary to the DVT, and the patient was in ICU for. So since that incident, we were thinking of conducting a research. But good thing is Asian people will have lesser chance of DVT compared to the European one. That is a good point that we have in our
but still in the post-operative follow-up, we should keep an index of suspicion. If patient complain of calf pain, all of a sudden acute onset, then we should think of DVT can be there.
Had a few patients coming back with calf pain, and we've got Dopplers done for them. Thankfully, none of them as yet had come out to be DVT, but we do keep that as a keep a lookout for that.
Now this is my case presentation. This chap, 21-year-old, had injury 5 years back. No such treatment was given that time. Probably he had some epiphyseal injury. And Sumit, can you comment on this X-ray? What is there? The quality is not so good. Still, some comment you can make over there. What is happening in this X-ray?
You see, at the very outset, the joint space on the AP view looks decreased, maybe because of extension lag of this patient. The knee maybe X-ray might have taken a little bit in flexion. I can't give so much of comment on the AP view. On the lateral view, I don't know, maybe little bit of patella baha I can see. Maybe
is there an issue with the slope?
Yeah, the complaint was patient of giving way posteriorly. There was a posterolateral instability. That was the patient's complaint.
Because the lateral X-ray looks as if there is some issue with the slope.
Yeah, this is not true lateral. That is why probably that is something. Okay.
Yeah, it's not of good quality, but the issue with this slope.
Yeah.
If we see, go through this. This is what MR picture of this one.
So he might had a tibial plateau fracture, if I can guess.
Yeah, somewhere it's on the.
Some sort of tibial plateau fracture that might have changed the slope, but it looks pretty okay. And the lateral slope is pretty okay.
Only on the half of the knee.
Okay.
This is what the MRI. He got 3-4 MRI. There was continuous the sort of partial ACL strain. And this is
how old was the injury, Rajiv?
4-year-old.
4-year-old.
Yeah.
So probably a scanogram, and go. Maybe I would have done a CT scan also for that particular patient.
Yes, I am just I don't have one true lateral view X-ray, and that there was a reversal of slope in that patient. This is what I did. I just did a closed vase osteotomy. Just osteotomize the tibial tubercle and close it. Open vase osteotomy and open it to get back the tibial slope on that side. That's now a 2-year follow-up. This is what patients I have. Weight bearing now. I have a scanogram post-op and with the weight bearing X-rays. But the important point to discuss is we have to keep in mind the slope also, looking at this the injury patterns and the instability part. Because nowadays lot of discussion over the failure of ACLs, and I had a few days back I had one trauma upper end of tibia, and the slope was totally reverse. And the patient again complained of restriction of movement. We revised the fracture, did osteotomy, and get back to the normal. So my point is just to keep in mind the slope of the tibia to such type of injuries, because MRI reports are really disgusting. Your comment, Dr. Deepak?
Yeah, absolutely right. As the standard teaching, Rajiv, that we used to learn from our postgraduate days, that if it's a bony thing, first correct the bony thing. So if you don't correct the bony, do the ACL, it's going to fail. So that's I think the message that should be given to the younger arthroscopy surgeon, that it's not the everything about arthroscopy. So one has to treat the bony part if it's there. If you would have done the ACL in this, ACL would have failed. Definitely.
Dr. Amit, your comment on the tibial slope nowadays, a lot of literature is coming on that.
Yes, Rajiv, absolutely agree, and then I would like to highlight those general orthopedic surgeons who are treating the proximal tibia fracture quite often, they usually, we as an orthopedic surgeon by heart, we are a hardcore bony surgeons, we look at bones only. We do not look at ligaments, which are not visible in the X-ray, and we do not usually measure as an orthopedic surgeon the alignments of the bones, and then we get carried away by saying, okay, little bit of alignment, off alignment is okay. That is very important, and absolutely agree with Deepak. Whenever you think of doing a ligament reconstruction, you think, especially in a chronic case like yours, after 4 years of injury, we must think about the alignment. If the alignment is off, without fracture, probably alignment has to be corrected. Either it is a sagittal or it is a coronal, whatever alignment. If it is off, even the rotational alignment, if it is off, it has to be corrected before undertaking any ligament reconstruction.
I think we
can... Rajiv, just a question. Why the tibial tubercle osteotomy?
Why to get into the actual to get in a proper way, because on the medial side it is difficult to do that. You just osteotomize in the front. You do the
yes, Rajiv did. I think
you can use a bifrontal.
And the tibial slope correction, it is not described to go with as what we do in standard STO medial. It is difficult. I think it was better just go through that and do the whatever opening you require to do that. From the medial side, it is difficult to control it.
Yes, Rajiv, you are absolutely right. If you read a Get Good paper, which he says that the biological fixation, you take out the tibial tuberosity up, then you do anterior to posterior osteotomy, you open it up so that you decrease the slope, you increase the posterior slope, and then use the same tibial tuberosity to stabilize your, the osteotomy site. Here, probably Rajiv has done osteotomy, and they stabilized the osteotomy site, tibial tuberosity osteotomy, and they stabilized osteotomy with the plate, and then he has refixed the tibial tuberosity. That is what I guess. That, okay, that's good. Well done.
Now I think we can finish. It is now 6 o'clock. And I really thankful to my faculties they for sparing their time, and thank you to Biotek also for arranging this. And it is always it is really great to have Dr. Deepak and Dr. Amit on the board. And I always try to keep them in loop, because their message and their information is very
Thank you, Rajiv. Thank you for the invitation. It was very nice.
Thank you, Deepak. Thank you very much, Rajiv. Thank you very much.
Thank you. Thanks a lot.
See you very soon in Nepal, probably after the Corona period, which we don't know when it is going to be over.
Look forward for that.
What is your prediction when Corona is going to finish?
2 years.
Okay, see you, sir. A nice time with you and all the delegates and the participants. We are thankful.
Bye-bye. Have a great day.
Thank you, everybody. Thank you very much.